All right. So on May 14th, the CDC released their clinical practice guidelines. I encourage everyone to read them. There's very cogent document, provides clear criteria for determining a person's HIV risk and their indications for PrEP. And it requires that patients receive HIV testing to confirm their negative status. And again, I think it really underscores the importance of counseling about adherence, risk reduction counseling, really encouraging condom use for additional protection as well. All right, and then more locally, the New York State Department of Health issued their own guidance for PrEP, and these are available on hivguidelines.org. But I'm going to show you how to dispense PrEP. It's easy. The science is not difficult. The thing that I think is difficult is implementing it in a healthcare setting, right? Because you really need to meet with the leadership at your institution. You need buy-in, and I'm going to talk to you a little bit about that. And we had a lot of providers that were like, no, this is not what I want to do. I think it's going to cause more unsafe sex. I don't feel comfortable with it. But with time and with data and kind of meeting and working these issues out, I think most turn around with the efficacy of PrEP. I do think that PrEP is going to be like what birth control did for women. I think for our generation, it's that same concept with preventing HIV infection. And I think we're going to move there. All right, so this is how you do it. So you got to pick a candidate for PrEP. So PrEP is indicated for individuals who have a documented HIV negative test, and they're at ongoing high risk for HIV infection. Their negative test needs to be done as soon as possible before you start. Remember, acute HIV infection, after about 2 weeks, flu-like syndrome, your virus will be positive, but your antibody test will not have turned yet. If you feel somebody has had recent risk within 6 weeks, get a viral load in addition to the antibody test, because if you start someone on Truvada and they're already infected, Truvada is not enough to treat established HIV infection. So what will happen is you'll have this virus that's replicating, you'll have this suboptimal therapy, and that's how you drive mutations. So you just got to really make sure they're negative, because and then Truvada in someone that's HIV negative is enough. But if they have undiagnosed HIV, they had recent exposure, you do an antibody, it's negative, but they're in fact infected, you put them on Truvada. Not only is it not going to work because they're already positive, but they're going to breed resistance that can then be transmitted. That's the only kind of sensitive issue really with PrEP. And really, PrEP is not meant to be used as lifelong intervention. You know, people mature, they evolve, you know, it's just really during that highest risk. And again, we got to target those that are most at risk in your communities, right? So for us, I think as well, you know, MSM of color, women of color, commercial sex workers, intravenous drug users, really get them, engage them in care, primary care, and offer this as another toolbox for prevention. It does work if you take it. All right, so providers need to obtain a thorough sexual and drug use history. So you got to feel comfortable talking about sex, drugs, and rock and roll. Are you comfortable? I think so. And you don't have to be perfect at it, right? You know, and sometimes if you have a care team that's better, like I have a social worker, she's fantastic, really resonates with young men very effectively. I kind of use her as my onboarding strategy a lot. But you want to get away from things like, do you practice unsafe sex? So the CDC is now moving towards like, you know, be a little bit more objective. So do you have sex? If you do you always find it difficult to always use condoms? But don't use words like unsafe. I am used to use that a lot. And I remember when I asked a patient, do you engage in unsafe sex? And he told me that unsafe sex to him meant having sex on a plane with the pilot. Did you know he could crash? So, again, do you have sex? Yes. Do you have sex with men, women, or both? You know, and patients will appreciate that candor, and they will be able to discuss more. But you do need to get into the weeds for this, because it's important. And then you also need to discuss safer sex practices and safer injection techniques. And then understand the difference between PEP and PrEP, right? PEP is emergency, right? That's a house staff that has a needle stick exposure. You want to get the meds on board within 72 hours, right? To abort HIV infection, but also for a high-risk sexual exposure, isolated case, PEP, post-exposure prophylaxis. Now, PEP is Truvada plus another antiviral agent. So PEP is basically the same thing that we give to people with established HIV infection. We just give it in this very narrow window so that we can prevent those first cycles of viral replication so that the exposure remains contained and your body's immune system aborts it. PrEP is not given after an immediate exposure, right? PrEP is somebody that says, hey, I want to take steps to prevent HIV. You got to rule out HIV infection before you start. But PEP is for, I've just been exposed to HIV, what do I do? So does that make sense? So oftentimes I'll take a pepper, though, and convert them to a prepper, right? So after they finish that month-long course, and then I'll say, hey, you've already, you've shown that you've had high-risk exposure. Have you thought about PrEP or pre-exposure prophylaxis as a way to really prevent HIV? All right, so what are the candidates for PrEP? So men who have sex with men who engage in unprotected anal intercourse, biggest risk, right? Individuals in a serodiscordant sexual relationship, so one's positive and the other's negative, right? That's another indication for PrEP. Transgender individuals, people who inject drugs, including hormones, stimulant drug use, especially methamphetamine, individuals with greater than one or more anal genital sexually transmitted infection, and individuals who have been prescribed non-occupational post-exposure prophylaxis but continue to engage in risk. And then anybody that engages in transactional sex, either sex for money or housing. All right, there are several surveys or risk assessments that you can distribute. This one is the one that's validated by the CDC. Actually, one of your speakers today actually published this, Don Smith. So it just gives a risk factor. So how old are you assigns you a score. How many men have you had sex with in the last 6 months? If you did have sex, were you insertive, receptive? So anyway, this is something you can distribute in the waiting room. You tally up the score. If it's 10 or more, then that's going to prompt you to have that conversation about pre-exposure prophylaxis. This one is very specific for men who have sex with men. There are others out there that are more tailored towards women, heterosexual, intravenous users, etc. All right. So the New York State Department of Health, contraindications to PrEP, very few. Drugs very safe, easy to take. Remember, this is the same medication that we've been giving to patients with established HIV for a while. All right? So really the biggest contraindications, if patients are not ready or willing to adhere, all right? Data supports that you need to take Truvada at least 4 days a week in order to reach that maximal protective effect. So if they're not really going to adhere to the medication, that would be a contraindication. And then the only medical contraindications are if they already have established HIV infection. Remember, Truvada is not enough for treatment of established HIV infection. And tenofovir can be a little proximal tubular poisonette. In rare cases, it can cause a Fanconi syndrome. Remember that one for the boards? Glycosuria, increase in your serum creatinine, or renal tubular acidosis, very rarely. So if they've already got compromised renal function, probably not a good idea to start on Truvada. But those are the only two. So they just need normal renal function, and they have to be HIV negative, and make sure to rule out early infection as well, and if they're not going to adhere. Let me just tell you that with HIV infection, what we're seeing, right, it is expensive to treat. You don't want anybody to become HIV infected because the rates of malignancies in those with HIV infection increases. The rates of cardiovascular disease increases. The NIH is now funding a trial called Reprieve. It's kind of like the Jupiter trial. I don't know if you guys recall the Jupiter. What they're looking at is HIV positive patients, low cardiovascular risk, and putting them on a statin early to see if it not only lowers lipid levels, but decreases inflammation. Because what we're seeing is men in their 40s and 50s with MIs and stroke. So again, once HIV interjects into the human genome, it does not go away. It stays in that reservoir, and it's still immunologically active. So really, anything we can do to avert it, I think, is going to be super effective. All right. So this statement is quite obvious, but it takes a while to wrap your brain around it. Although consistent condom use is a critical part of a prevention plan for all persons prescribed PrEP, lack of use of barrier protection is not a contraindication. If they were always using condoms, they wouldn't need PrEP. So this is really to help people who find it difficult to always use condoms for whatever reason in their life. You know what I mean? And I think what happened also with women in birth control, you know, this kind of shaming. Why is it you're going to be on the pill? What does that say about your behavior? Again, I think we have to refocus this argument and really look at things that we can do to prevent, you know, HIV and to assist people, especially young people, in taking steps to do that. So once you rule them out for HIV, so what are some of the other considerations? Well, does the patient have chronic active hepatitis B? So surface antigen positive. The reason for that is that tenofovir and emtricitabine, in addition to having anti-HIV effects, they're also great drugs for Hep B. So it's great if someone is trying to prevent HIV and has chronic Hep B, you can put them on Truvada. You just want to know, because if they should interrupt therapy, they may have a flare, just like with anybody else with the chronic hepatitis B. If you put them on anti-B therapy and then they should stop, you may see an increase in their LFTs. Is the patient pregnant or attempting to conceive? Truvada, category B, safe in pregnancy. The majority of mother-to-child transmissions now occur because the mother acquires her HIV during pregnancy. That first HIV test is negative, gets exposed during her pregnancy. The amount of virus during acute HIV infections in the hundreds of thousands to millions. Transmission in the womb, in utero. Again, a woman that's at risk for HIV during a pregnancy really should discuss PrEP. All right? Category B, so far there's been no signal for teratogenicity. Adolescents, I think they're a great group, but in certain states you need parental consent before you can start them. That may be difficult to get, but once they're past that Tanner stage 2, you know, I mean, I think the safety and the efficacy is still there. So is the patient taking other nephrotoxic drugs? Remember tenofovir? So if they're on a lot of NSAIDs, if they're on other drugs, you may have synergistic effects. So you really want to obtain that history. I think especially NSAIDs. And then tenofovir can also cause about a 1% drop in your bone mineral density. So if they're older, or if they've already got osteopenia, osteoporosis, then, you know, you may want to get a DEXA or, you know, check a vitamin D, but it's not an absolute contraindication. So those are basically the issues that come up with it.